go back and review. This will be put on YouTube or Sure's Path at sometime this afternoon. I cannot do it right away. It'll take me a little bit to get it transferred over. So again, I am recording. Please course key in. Let's get started. Anybody else who's late, well, that's just an issue. So please course key in. Okay. All right, talking about cellular regulation today. So this is week 4, day 2. This is the lecture you would have had we done class on Wednesday and you were doing your test today. So I'm going to go on. I am hoping that you guys see the
Can you
slides.
pull back up the course key?
I cannot right at the moment. It'll be just a few moments and you'll see a slide with it on it again in a few minutes. Okay, this is going to, that's the one that's embedded in my presentation today. So please get course keyed in there. Hopefully everybody's ready to go. Got a lot to cover. Okay, cellular regulation, that's going to be everything that happens inside our cells and inside our body. Of course, our cells, if you remember back to your anatomy and physiology, we talk about each cell having its own nucleus and we have ribosomes, we have DNA, RNA, etc. All those wonderful structures that are in our okay, I'm just going to answer this. You do not need to worry about if you're in this and you're hearing, you're good. Don't worry about your ID, okay? So just saying, make sure you've got course keyed in. That's more important than that we're attending. Otherwise, we're just going to be sitting here talking and not getting anything done. So let me go on. Anyway, we have hormones and neurotransmitters that help manage and regulate our system. It's very important to realize that malignant cells are our cells. It's just malignant cells are cells that have gone awry. They're no longer functioning the same as their parent cell did. Something has happened. They're faulty. They may not be able to replicate the same. They're going to be called dysplastic or dysplasia because the cell growth is abnormal. Malignant cells, again, are our own cells. They don't come from someplace else. This is a cell that has somehow or another changed in its functioning. It may be replicating too quickly, maybe replicating faster than it's supposed to, and it's not providing the function that its parent cell did. Please mute your mics, please, because I can hear you. What are some psychosocial concerns associated with the diagnosis of cancer? Well, there's a lot of people, you know, I'm sure that there are folks in our class out of 46, there's bound to be a few that has had cancer. There's concerns about, you know, the depression that you end up with, the fact that, you know, you're struggling with that, the ideas of, I'm sorry, I'm dealing with something else right now. Let me get back out of here and find out what's going on here. I definitely do not like doing, I wish notifications would quit notifying me. I don't care. Let's see if I can get my notifications turned off because it's being very distracting to me right now. I'm so sorry. Okay, there we go. So cellular regulation, it's from our cells being normal to the fact that they change and then they become malignant somewhere along the way. Here's the course key again for those who did not get course keyed earlier. I tried to throw a couple of these into the slides so that I could catch people as they're coming in. So please course key in if you're coming in at the last minute here. There we go. Okay. This is a table that's directly from Giddens, page 104, table 10.1 from your reading. I did have this pulled up. Let me see if I can get there. This is Giddens here. So if we go into Giddens and we go to this particular table is right here. And it basically shows the comparison of benign and malignant neoplasms. In class, they wanted us to have you turn into that book and then as a class project, put in the information from that. So when you get off here, I would make sure I would note this information because your slides are not going to have that particular slide all the way filled out. I will probably take my slides and try to add them to SurePath here so that you can have the full slide completed. I did complete my copy of it. So we have different characteristics of our cancers or our cells. If the cancer itself is encapsulated, it easily moves. Usually that's benign. And it's rarely malignant because it's encapsulated. Our body has been able to wall it off and keep it in its normal place. If it's differentiated, that means that those cells, if they're benign, they look very much like their own parent cell. They don't have too much differentiation different than their mother and father cells. They will grow as usual and function usually as usual. But if they're malignant, they're poorly differentiated, meaning they don't look like their parent. They lose their specialization. They lose their ability to function the way they're supposed to. So instead of it functioning as a heart cell or as it functioning as a stomach or a gastric cell, where it might produce mucus, etc., or enzymes for producing or breaking down our food, it doesn't function the same way. So it doesn't do what it's supposed to. Metastasis, if it's benign, it typically is not going to metastasize. It's going to stay in that same area. It doesn't go anywhere else. But if it's malignant, it is capable of moving to other areas or spreading. So it's very important during the treatment of cancer to catch the cells as quickly as we can to get rid of them or to destroy them with chemotherapy, radiation, or other types of treatment that we use or surgically remove so that it cannot spread. Recurrence, if it's benign, it rarely moves or grows except for in the place where it started. So it can come back if not completely removed, but it does not, it's just very rare. Whereas a malignant cell possibly can come back at the same place or especially if there's cells left or we aren't able to get everything. If we leave a little bit, or maybe it goes to the lymph cells or goes to a distant tissue, then there's a possibility of it being recurrent. What sometimes happens, we'll say, for instance, with ovarian cancer. Ovarian cancer occurs when a ovarian cell becomes malignant, and if we don't get rid of all of that, then it can actually spread, or it may already spread. It goes to the lymph nodes and it gets into the system, and then sometimes it will drift to another area and cause cancer in the lung. But when you look at the cells, what's really interesting is that the cell type is still that of the ovarian cell. but it's now found in the lungs. So we know it's metastasized. So, but the cell itself will be the same type of cancer that was the cancer that was in the ovaries. If it goes to the brain, it'll still look like that. We do a biopsy and we'll look at those cells, and those cells are the same. And we know that, oh, okay, this is cells that have now metastasized, or they've moved and they're now growing in the brain, they're growing in the lung or someplace different. And that's what metastasis is. It's a distant reoccurrence of those cells. Vascularity means that with benign cancers, it's very rare. They can vary, they can have blood vessels, but they're usually more organized and normal, again, normal in structure. There might be slight vascularity issues, but malignant tumors often show high vascularity. They have the ability to actually turn on cells that actually proliferate the arteries and veins and capillaries so that they can get more food, so they can get more nutrition and grow. So they can actually cause all sorts of issues with the vascularity of our cells. So that's important to know. Of course, mode of growth, it's expansive. If it's malignant, it's infiltrative and expansive. And then the cell characteristic, again, if it's benign, it's very similar to the parent cell. If it's malignant, it's very abnormal or very different from the parent cell. So risk factors, I've got a few folks here that still need to get course keyed in. So let me get the course key back up. Tiara, try that now and see if you can get course keyed in. If anybody else has not had a chance, the course key is there, and the code, if you have to, you put a code. If you're using your phone, you just take a picture. If it's not, then use the code there if you're using your laptop, which is the P4LIQXC. So everybody, please try to get course keyed in if you can. Okay, let's go on. Let's see if we can get through this. So what are the risk factors for cancer? From your reading, I hope that you paid attention to what the most common types of cancer were for women, for men, and what they were for children. For women, the most common sites, and you may want to make note of this, are the breast, lung, or colon, or rectum. Among men, the most three common sites for new cancer diagnoses are prostate, lung, and colon. And then for children, 28% of cancers that affect them are from leukemia. And then another 26% are usually brain or central nervous system. And those are the most common cancers in childhood. It is also estimated that 80% of cancers diagnosed among those 55 years of age and older are connected to other risk factors such as smoking or non-smoking or being exposed to secondhand smoke. I don't know if I actually believe that particular statistic, but that was what we were given. That's interesting. So secondhand smoke is estimated to cause 3,600 lung cancer deaths in the United States on average year to year. And that's the reason why we harp so much on stopping smoking. The probability, of course, of cancer with age, we do see more cancer as we age. You're more likely to have your cells go awry or not divide and multiply like they're supposed to. Errors get in there, just like little computerization errors in the code, and the code doesn't get spread to the parent from the parent cell to the daughter cell, and then it causes issues. Most often, lower income workers and community members are more at risk for cancer just because of the cost of prevention lack of going to the doctor, etc. Um, Individual risk factors, of course, is age, smoking, infectious agents, genetic risk, radiation, carcinogens, nutrition, and physical activity. So, or lack of physical activity, not staying up with that. So, I'm going to give you a little look at my notes here. Again, I'm going to put these in SurePath so you have access to them. So you can catch up with your note taking here for a little bit here. So that's just what I said: age, smoking, infectious agents, genetic risk, radiation, carcinogens, and nutrition. Okay. So what are the psychosocial consequences? Of course, development of cancer. It's very scary. Fear, stress, anxiety, changes in family dynamics because of the stress, especially if the person who has cancer was the main financial contributor in the family. It's going to be more difficult to pay, expenses to pay bills, um, pay your home um, mortgage, etc., pay off your car if you're not able to work and you're not able to earn that living. If it's the parent that's taking care of the children, then we've got a lack of ability to take care of those kids and stuff. And the support systems get iffy. I mean, it becomes scary for the entire family. What happens when mom is not able to do the things that she used to do? These days, of course, we have two people in the family. If you're in a traditional um, family of two parents, that instance when one of them is ill or not able to work, that really takes a bite out of your expenses and a bite out of your ability to support. We're very fortunate today that we have still some protections with our jobs, with like FMLA and others that people did not have 30 or 40 years ago. I mean, when you took off sick, if you didn't have sick days, that was just tough. Your employer didn't have to support you. Congress many years ago passed the FMLA rule that said that your job is protected for 12 weeks. That's the reason why we have long-term care insurance and short-term care insurance. Very good for you to take those out, by the way, when you take a job, because you never know what's going to happen. What happens if you're not able to earn a living? How are you going to be able to make the bills or make ends meet? Okay, history of assessment. So we're going to take our history from our patient. What were the symptoms that they came with as far as their cancer was concerned? What type of what did they note first? Were they having, headaches? If they had a brain tumor, if they were having issues with their GI system, did they have blood in their stool? Did they have, when they urinated, did they have blood in the urine and stuff if they had bladder cancer? A lot of times, blood is one of those signs that tells us something's not normal, something's not working the way it should. The cells become friable, meaning that they're weak. They tear apart, and then that causes the bleeding, especially with the gut, coughing, in our lungs. If that cancer cell is there, usually those will rupture and they will cause them to bleed. Again, they don't function the way they used to. They're not as strong as the cells from their parents. So that's why we're seeing the blood, etc. So blood in your sputum, blood in your urine, blood in your stool, definitely a precursor telling you something is not right. So that's our warning signs. What pain that's not normal. Um, Again, we may see lesions, we may see some asymmetry in an area. A tumor we may be able to palpate. For instance, breast tissue may not feel the same. That's the reason why it's important to do your breast self-exam in the shower every month, about the same time each month, so that you can make sure that everything is the same. Check underneath your armpits, make sure there's nothing palpable there. If we're listening to the lungs, we're going to be listening for abnormal breath sounds. And again, blood being that number one cardinal sign of a lot of different cancers. Unexplained weight gain, loss for no reason, headaches, seizures, vision changes, abdominal pain, fatigue, just fatigue for no reason. Of course, changes in bowel and bladder, white patches on the inside of the mouth or tongue. So when you go to the dentist, that's what he's checking for when he does an oral exam. And of course, any abnormal discharges, any problems with persistent cough, etc. Bruising without a reason. Okay, that could tell us maybe that we have something wrong with our blood system. Diagnostic testing, we're going to follow up on those areas. For breast, we would do a mammogram and then maybe an ultrasound if we saw something that was abnormal. Lab tests are now coming into vogue with a lot of our different cancers because we can actually draw blood. And there's certain markers that we can look at that increases if a person has cancer. And of course, biopsy is our number one, looking at those. We also can do genetic testing and looking for BRCA1 and BRCA2, which are breast genetics that make it that says that you have a higher genetic possibility of getting breast cancer. So biopsy is the definitive way to diagnosing cancer. We take a tissue sample, we send it over to the histology lab. If there's malignancy there, we can actually tell what type of malignancy, what type of cells. There are needle aspirate, or we can actually take a sample by needle, where we put a needle into the tumor and take out some cells and aspirate those cells. We could do an incisional biopsy, where actually we cut and then take a piece of the tissue or a wedge. Then they can do staging, and staging is where it tells us whether or not this is a stage 1, 2, 3, 4, or non-stageable is 0. But it tells us exactly how proliferative, how far expanse that particular cancer is grown. We can also do bone marrow examination. We can do CT scans, PET scans. Now, PET scans, we give the person a radioactive imaging contrast material like glucose, and cancer cells take up glucose really fast because they have a higher metabolism, and then we see where that's being taken up. It tells us how far spread the cancer is when we do a PET scan. Cytology studies look at the cell types. For instance, an example would be pap smear. And then liver function studies. We may do a guaiac test, which is a test for blood in the stool. We take a stool sample, we put it on the card, we put a couple of drops of a reagent, and it tells us whether or not there's blood in the stool. And of course, there's tumor and genetic markers, which we talked about a little bit. So, what is the assessment? We're looking at grading and staging. It's the way of grading is looking at the cells and seeing how different they are, or differentiation has occurred. Are they completely different than the normal structure of the parent cell? If it's well differentiated and it looks like the mother cell, then it may be more benign. Again, we said that poorly differentiated cells, meaning it has little resemblance to its parent, may be more malignant, and it can be very aggressive, so we know how aggressive it is. Here is the staging, and I'm just going to put it over in where you can see this. If we have a staging GX, that means it cannot be assessed. We cannot tell how far it is. G1, it means that it's a low-grade cancer. That particular cell looks very much like its parent. It's just barely a little different than its parent cell. And then moderately differentiated is moderate to the cell. That means the G2, G3 poorly differentiated, meaning it's a high grade cancer. And then, of course, G4 It's completely different. It doesn't look anything like its parent and doesn't have any of the same function. And again, for anyone who cannot see the slides, make sure that you have signed in as a student. If Deja, if you're not signed in with your student ID using the app, that's why you cannot see the screen or see the slides. So just follow along as best you can if you're not able to get signed in correctly. Okay. So here's another cell. I'm going to go ahead and keep my notes over here so you can see them here. On Giddens, page 108, it goes through the degree of differentiation of a neoplasm. We have above example 1, TX, NX, MX, GX. Okay, T is the tumor, N is whether or not it's in the lymph nodes, and M means whether or not it's metastasized. This is how grading is done. G then tells us how differentiated the cell type is. So if we had a cell that was TISNOMOG2, that means that that tumor is in situ, the meaning it's encapsulated, it's in within the tissue. It has not gone anywhere. There is no lymph nodes that are being affected. There is no metastasis, and it's just a little bit different than its parent cell. T3, N3, M3, G3, as it's showing, means that this cell is a stage 3, that there are lymph nodes that are being impacted, and yes, it has metastasized to a different area, and it's very highly different than its parent cell. Not quite at the 4, which would be the highest grade, but it's almost there. So the higher the larger the tumor, the fact that it's in lymph nodes and has moved means that this cell is going to be, or this cancer is going to be very difficult for us to be able to fight. So, what can we do in order to fight this cancer? We're going to go ahead and we're going to try to have a healthier diet. We're going to make sure that we stop our smoking, avoid some excessive sun exposure. So, if we can reduce our risk of getting cancer, we're better off. We don't have to worry about the risk of that as long as our genetics are not priming us for cancer. So we're going to keep healthy, keep active, try to eat a balanced diet, try to eat good, and again, take as many risks as we possibly can out of our system or out of our ways. So again, stopping smoking and keeping as healthy as possible. You're still not guaranteed you won't end up with cancer, but early detection these days, cancer used to be, oh, you have cancer. There was nothing much they could do. My grandmother was diagnosed with cancer back in the 1940s. There was little they could do. They just kept her comfortable. There was little treatment. Um, of course, I wasn't around at the time, but I remember being told stories about her and how she was just all of a sudden, more fatigued, and she had stomach cancer of some sort. And a few months later, she passed away. Nowadays, we do have some treatments for a lot of these cancers. They're not as severe as they once were. Early detection is the key to this. So, making sure you keep up with your exams, that you get your mammograms, that you get, watch your symptoms. If you have blood in your stool, blood or in your urine, have it checked out because again, that's not normal. You should have it checked so that you can make sure that there's nothing else going on. Again, here are the secondary preventions: mammogram, prostate specific antigen, PSA, as we call that, colonoscopy, and then the guaiac test for occult blood. That is the FIT test. Guaiac test, again, is that card. Put a stool sample on it, put a couple of drops on it, and it turns a different color. We know that there's blood there. We also can do Cologuard. Cologuard is lovingly called poop in the box. They send you a box in the mail. You take a stool sample, you follow the directions, put it into the container, label it, you send it back, and then they run it through a histology department, looks at it, looks at to see if there's any type of cancer cells in that sample that you sent. Okay, Giddens page 109. What are the collaborative interventions? Okay, the strategy for treatment just depends on the type of cancer it is. There's a lot of different cancer treatments going on today besides just chemotherapy and radiation and surgery. Those were the top three for many years. That was all we had. But now we do have other types of medications, other types of surgery that we can do, or other types of stereotactic surgery, where we used to have brain tumors that we could not treat because they were in areas that were too iffy for us to be able to access. Now with stereotactic and different kinds of computer controls, we can actually do more surgical procedures than we used to. We also have palliative surgery. Palliative surgery is performed not to cure, but to improve the quality of life and survival time. They can go in and actually palliatively go in and debulk a tumor, especially if they don't think that they're going to be able to get rid of that tumor, then they can at least take part of it away so that it's no longer causing, pressing on vital areas, vital organs. If it's in a brain tumor, then it's not pressing on certain parts of the brain or on the spine. A lot of times, brain surgery is done with those metastatic cancers that, again, we don't have treatments for it right now. But we do have treatment now for pancreatic. I cannot talk today. We do have treatment for pancreatic cancers. We used to say that if you had pancreatic cancer, that there was nothing much we could do. We're going to send you home and just let you die because there was nothing we could do. Now we do have treatment also for liver cancer. That was the same way. We do have some really good treatments out there coming on board for all sorts of cancers. So cancer no longer has to be a big C, it can be a little c. So here's the collaborative interventions. Be aware of these. Surgery, of course, it's fairly clear. That's taking the cancer and cutting it out. Radiation, we actually are using a radiation type process where we're putting radiation into there. Now that could be from a machine that actually radiates the area, or we could also use some type of pellets or something of that sort that we implant into the cancer, and it actually kills the cancer. We can actually instill a radioactive isotope into the bladder or something of that sort, where you hold on to it and then you pee it out later, 45 minutes to an hour later, then you go relieve yourself. So there is a lot of different treatments that we're doing. There's hormonal treatment. Hormonal treatment meaning that we are cutting down on the hormones or impacting, so that we're doing hormone cutting off the hormones a lot of times, because hormones actually, like estrogen and progesterone, can actually proliferate a cancer and make it grow more quickly. Whereas if you take the hormones away, then that cancer slows or actually dies because it is driven by the hormone of that area. Again, a lot of different chemotherapies are out there. We've had the same chemotherapy like cytotoxins for quite some time, but now we're coming up with some MABs and some immune therapies, targeted therapies, biologic therapy. In lab, I like to show a T4 cell treatment that they're now doing, and it's really growing in popularity, where we actually take your T4 cells, which are your targeted cells, and your white blood cell count, white blood cells, and then we're actually making them improved by giving them the ability to go in and target the cancer and get rid of it. So we're basically programming your cells to identify the cancer more effectively. So a nurse conducting a physical assessment on a patient with suspected cancer, which of the following findings should the nurse document? And you would want to select all that apply that are correct. So let's look at the presence of skin lesions or bruises. Yeah, we would definitely want to note that. Uh, patient's blood type, well, doesn't really have anything to do really and truly with identifying. There's no blood type that has a higher incidence of cancer than any other, so that's not true. Changes in weight compared to previous measurements, yeah, especially if they've lost a lot of weight for no reason, they've not been trying or gained weight. D, hair loss on the scalp. Yeah, that could possibly be a symptom of some type of cancer. Hair loss can be especially like thyroid cancer, etc., and a few things like that. Distension of the abdomen. Yeah, that possibly could be, especially if there's a tumor or if there's something that's going on with the stomach. Patient's favorite food? Nah. So it's going to be A, C, D, E. So exemplars, again, exemplars are examples of the type of that we're, the topic that we're dealing with. The exemplars that go along with cancer is, again, breast cancers, lung cancers, prostate, and leukemia. Those are the um, highest types of cancer out there. Breast for women, lung for both men and women, prostate for men, and of course, leukemia for children. So here's a example of breast cancer. As you can see, that's a tumor that's inside the breast tissue itself. This is found on mammogram. It shows, again, what are the risk factors for breast? Of course, it's gender. Women have a higher incidence of breast cancer than men do, but men do also get breast cancer. The older you are, the more likelihood is that you will get cancer. Because 1 in 4 after age 70 will develop breast cancer. Menstrual and pregnancy history. If you've never had children, if you're gravida 0, para 0, you have a higher incidence of breast cancer. Obesity, yes. If you're overweight, you have a higher incidence. Also, hormone replacement therapy. If you're on hormone replacement therapy and your cancer is driven by estrogen or progesterone and you're taking more of that, then the possibility is yes. Also, breast cancer metastasizes, like I said earlier, to the bone, the lung, brain, and liver. And again, treatment for breast cancer depends on the stage. Modalities that are used for breast cancer is surgery, radiation, hormone, and targeted therapies such as chemo, etc. Lung cancer. Lung cancer is the leading cause of cancer death of both men and women. So make note of that. We have breast that is the most, if you were talking women alone, it would be breast. But if you're talking men and women, the highest incidence now is lung. That was not true in 1950 and 1960. It wasn't until women women didn't smoke very much. I mean, yeah, they show it on on the old movies. You can pull up a 1930s or 1940s movie and see the socialite lighting up a cigarette and blowing smoke. And they thought that was pretty sexy, I guess, back then. But the problem is most women, majority of women did not smoke. So breast lung cancer was not a problem. Now it is because more women were smoking than in the 50s and 60s. It became more popular. Um, we still have quite a few people, both male and female, smoking today. Try to encourage your children and your grandchildren not to ever start smoking because we do know it is a risk for cancer. Back in the 50s, it wasn't on the cigarette packages that it caused cancer. We didn't know that. It wasn't until the 60s or 70s when they started seeing the incidence of cancer increase that we've put 2 and 2 together and it came up lung cancer. So small cell lung cancer, um, there are 2 types of lung cancer. There's small cell and non-small cell lung cancer. The latter, the non-small cancers comprise of 85% of all lung cancers. Prognosis is generally quite poor because it's usually detected at a later stage, meaning people don't report that they're having issues with breathing or they've had this nagging cough that's lasted for a long time. If you've been a smoker, you probably should every now and then have a chest x-ray done once every 5 or 10 years so that you can take a look to see if there's anything suspicious. If you're coughing up any type of blood or have a chronic cough that just won't go away, it needs to be checked out. The majority of lung cancers, almost 80%, are the result, again, of long-term exposure to cigarette smoke. Tamoxifen, make note of this. Again, tamoxifen is a drug that is used for the treatment of cancer, and it blocks estrogen from reaching receptor cells in breast tissue. It's actually an aromatase inhibitor, and it is starving estrogen positive tumors from the hormone they need to grow. My cancer happened to be estrogen and progesterone related. So I didn't do tamoxifen because tamoxifen has a high incidence of stroke and PE associated with it for some groups of people. And I happened to be one of those groups of people. So I did a different aromatase inhibitor. And I did that for 5 years to reduce my risk of recurrence of cancer. So that's what tamoxifen is. It decreases the risk for cancer. It treats the cancer, and then you can also use it to prevent the risk of metastasis or recurrence of the cancer. So it does have side effects of hot flashes and mood swings, and of course, increased risk of blood clots. And again, the increased risk of blood clots was the reason why my doctor did not recommend that for my genetics. Okay, a nurse is assessing a patient with suspected breast cancer. Which of the following findings should the nurse prioritize reporting it to the physician immediately? Well, the patient is going to express anxiety about the diagnosis. I haven't met anyone yet who did not get anxious when they were told they had cancer. The patient has a slightly elevated heart rate. Well, that's due to the anxiety. Patient reports a new lump in the other breast. Yeah, guys, I think that's probably the important one. They're going to have difficulty sleeping because they're anxious. So again, if the patient has in the opposite breast an area that they feel is new, that definitely needs to be checked out because possibility that when you have cancer in one breast, it's very likely that you may end up developing breast cancer in the other as well. Okay, this is prostate cancer. Again, the prostate is the male bladder is, of course, up in the abdomen. Then below the bladder, of course, is the urethra, which is quite long in the male. On either side is a kind of walnut-sized gland called the prostate, and it encircles the prostate does around the urethra. As it increases in size, it actually starts pressing on the urethra that decreases the urine flow, or it can cause difficulties with urine flow. So um, sometimes those cancer cells can, from the prostate, can go into the lymph nodes, and then they can go to the bone. So it's very important that we look at the prostate to determine what type of cancer it is, how aggressive it is, and how much treatment. So if it does metastasize, prostate will go to the bone, lung, liver, and kidneys. Prostate cancer is also the most common type of cancer in men. So 99% of those prostate cancers occur in men older than 50 years of age. So if they get cancer, um, it's usually because they're over age 50. There are um, accounts of men having prostate cancer into their 40s, though. So definitely any type of urine flow or flow issues should be checked out. Lymphocytic leukemia. That is characterized by the overproduction of malignant and immature white cells known as blasts. Blasts accumulate in the bone marrow. Of course, they inhibit the production of normal cells, such as red and white blood cells and platelets. A person may have symptoms of fever, infection, shortness of breath, tachycardia, bleeding, and bruising. Bruising is the number one thing that we see, especially with children, unusual bruising. And they always have a little bit of a paleness to them. Their color is a little off. Acute lymphocytic leukemia is the most common type, of course, in children. Treatment usually results in the disease being cured, but it's not a successful treatment for adults. St. Jude's Hospital has done an excellent job in um, research and treatment of children and children's cancer. So they treat a lot of leukemia in children there. What is the most common cause of cancer-related death among men and women again? Think about that. Which one of these? Lung, breast, colon, or liver? Which one, if this was a question on the test, which will be exam 2, not the one coming up this week, which one is the highest cause among men and women? And I said that earlier. So again, I see here, yes. I have a couple of people chatting in on here. So if you said lung, yes, lung, thank you. It is the most common between male and female. Make sure you choose lung on that question. Then the most common cancer in women, breast, yeah, okay. Yeah, you guys are getting it. And if it was the most common cancer in men, you guys are going to say prostate. So that's good. Excellent job. You guys are paying attention. I appreciate it. A patient is diagnosed as having a tumor classification of T1N1M0. From the classification, what do you know about this tumor? Okay, if you were to be given this on a test, T1 says, yeah, they do have cancer, and it is in N1 does say it has spread to the lymph node. But M0 means what? Yes, B. Miss Fish got it too. Yes. Miss Sherry, good job. Okay, B. Yeah, you guys have got it. What is the only definitive way to determine if tumor cells are malignant or benign? Yeah, you guys are getting this. You guys have got this. Thank you so much. You guys are doing a good job. It is C, pathological evaluation. We're going to send those tumor cells and have the pathologist take a look at it and see. They are so expert. It's quite amazing. I've actually attended, if you ever get a chance, you might want to see if you can, if you work in a hospital, see if, if there's any way that you can attend tumor board or tumor rounds sometimes. It's quite interesting. They'll sit around and they'll review. There's breast cancer tumor rounds, and then they'll also have GI and other tumor boards will get together. They actually will review the patient's case, and the surgeon, the radiologist is there, the chemotherapist, the doc that's going to be doing chemotherapy. They'll discuss as a panel different, more difficult cancer cases, and any of the physicians can bring a case if he wants his colleagues to be able to look it over. And I learned so much sitting in those tumor rat boards. By the way, if you become a work for cancer group, they actually hire people that keep the data and the statistics, and you become a part of that tumor board. You can learn so much there, so much. Okay. What is the only definitive way? That was pathology then. So, palliative care. CMS defines palliative care as we're going to optimize the quality of care of the patient. Now, palliative is not hospice. Palliative care says this person has a diagnosis or has a disease or comorbidity that limits the amount of their life expectancy of some sort. If a person has diabetes, if they have COPD, if they have congestive heart failure, they don't have to have cancer. But if they have cancer, then they can become they can get palliative care. They can get enrolled with a palliative care company that will actually come in and help them maintain their quality of life. And those services are based on an assessment of what their need is. So definitely, I wish they would call it something else. One of these days, maybe we can get them to change the name of this because a lot of times patients don't understand the word palliative. That palliative is, you can still, if you had a gallbladder attack and needed your gallbladder out, palliative care, you can go ahead and have that gallbladder. You can still have treatment. You can get treatment for any of your other conditions or any condition, but it just provides more services. And it's a way for a patient who has some limited ability now to get maybe someone to come in and help them shower a couple of times a week or have meals delivered 1 or 2 times a day or have transportation even to go to their cancer treatments or transportation taking them to their doctor. So it's really good program. So palliative care, again, unlike hospice, provides both curative and symptomatic therapies. That's the difference. So if it says this particular service provides curative treatments and symptomatic therapies, you would choose palliative over hospice. Make sure you choose the right one if you have that type of a question. Scope of palliative care. Again, palliative care and hospice care are part of the continuum of care. Um, the earlier a person gets in, the sooner they can start getting assistance. And what we're trying to do with palliative care is prolong their quality of life, prolong their life by giving them the support they need and decreasing their stress. Um, again, hospice is provided by Medicare again, and Medicare says that the survival of the person is 6 months or less. But with palliative, uh, it can be any time that they have a condition that's going to limit their life longevity. So that's a whole difference. Um, with hospice, it's a team approach. There's usually a nurse, there's a physician, and other members, including social work, chaplain, pharmacy, physical therapy, occupational therapy, speech and language pathology, of those things that are available. But again, it's that social support, it's that the support in the home. Um, it's good to have, that support, especially when you're having an end of life type situation. There's differences, by the way, in companies and the way that they handle or approach hospice care. I would talk before choosing a company. I would actually talk to the representative and ask them, okay, what is your theory of hospice care? What do you provide? What type of support, especially if you're wanting to go home or if you have a family member that wants to be home, trying to get that person home. We will be doing a simulation in lab. We're supposed to be doing that this week, and it's about a patient who has cancer. So it'll be interesting to see how that progresses in our lab with that simulation. Okay, which discipline of the palliative care team assesses and evaluates the ongoing needs of the patient's physical, emotional, spiritual well-being, as well as advocates and provides referrals to other disciplines of the team? Now, this is always a difficult answer because a lot of times people choose the wrong one. So which one do you think it is? Okay. I love the fact that you guys picked up on the nurse. The couple of you are already chiming in that it was the nurse, the nurse, the nurse. Yes, it is the nurse that is responsible for that. And they're usually the navigator that navigates that patient through all the different things. They can actually send the patient to the social worker, send the patient to the clergy. And of course, they keep the physician informed of what's going on. If you've ever worked in palliative care or hospice care, then the person who actually sees you all the time is not the doctor. He might see you once. It's actually the nurse that sees you every week and or every few days that follows up and makes certain that you are getting the care and getting the support that you need. Well, guess what, folks? This is the end of my um, presentation. I am wanting to go ahead and pull back in. And if you guys did not get course keyed in, make sure you get course keyed in. I'll pull up the course key. Was there any questions about anything else? Now, we will be, those of you who had lab today, we're going to have to figure out how to get you back into lab to make up these 4 hours that we're missing today. I do apologize that we're not able to do lab the same way we can do the lecture. I wish we could, but we haven't been able to figure that one out because we still have to have you there in person. Let's see. And I'm looking here. There we go. And I'm going to pull back this up. There is the course key again. Okay. Again, it's just a matter of you signing in to your student account instead of signing on with your personal ID. Again, if you could not see the screen, I will actually save my notes to SurePath. I've updated them. I've added my information. So I'll put those on SurePath so you guys can have access to that. Should you memorize the table, it would be good to know the information that's in that table as far as that it's differentiation of the cell. If it's highly differentiated, meaning it's just like its parent, or poorly differentiated. It's the opposite as far as differentiation goes. Differentiation means that I don't have any differences between me and my parent. Poorly differentiated means I'm very much different than my parent cell. So as long as you've got that down, that's a good way of starting. Again, know the modalities of cancer, which is radiation, surgery, chemotherapy. And then we should be good. Um, Okay, I don't have anything else for you guys right now. It looks like this was a fast one. Um, don't have to worry about signing out as long as you course keyed in. We should be okay with that. If you got course keyed in the first time, then you're probably fine. I'm going to go ahead and sign out, get me some coffee, and then I'll come back at our normal time for our class. Yeah, what time is that class? Typically, I'm looking real quick. I'm sorry. I'm fiddling around. We typically do Monday's class with 163 at 11 o'clock. That's another hour from now. Um, yeah, I see. Yeah, thanks, guys. 11 o'clock. My question is, that's an hour from now. Would you guys like to do this at 10:30 and be earlier? I've got a few people saying yes, sure.
Yes.
Okay, I tell you what I'll do. We'll start back at 10:30 then because we're ending so much earlier with the 160 group. I'll come in and again, I'll be sharing both PowerPoints on SurePath. I'll be putting the 160 on the 160 SurePath and the 163 on the 163 SurePath or Evolve so that you guys have access to those notes. We'll start back early here at 10:30. That way I can get you guys back out and then you can be done for your day, okay? If everybody's fine with that, then I'll see you guys back at 10:30, okay? All right, guys. Stay warm. See you soon.
Your call has been forwarded to voicemail. The person you're trying. Yes, it's been forwarded to voicemail. The person you're trying to reach. Bro, I think I just love that. This is like in my fucking.